Welcome to Menopause Wise, your go-to podcast for all things evidence-based in the menopause verse. I am Dr. Supreet Patel, an MD gynecologist, a menopause health advocate, a postmenopausal woman, and the founder of Menopause Wise. And I'm so excited to have you join us on this journey. Whether you're a healthcare provider looking to stay on top of the latest evidence-based practices, a woman navigating your own perimenopause or menopause journey, or a partner or family member eager to support a loved one, this series is designed with you in mind. Our mission through Menopause Wise is to close the menopause knowledge gap by bringing you the latest research, expert insights, and practical advice, empowering you to make informed decisions about menopause and perimenopause. Welcome to today's episode of the Menopause Wise podcast on brain fog and menopause with Dr. Alison Shea. Dr. Shea is an associate professor in the departments of obstetrics and gynecology and psychiatry at McMaster University. She completed her fellowship in menopause and reproductive mental health and her residency in OBGYN at the University of Toronto, Canada. She is a board member for the Canadian Menopause Society, a Menopause Society certified practitioner, and the chair of their examination committee responsible for certifying North American menopause practitioners. You can find her sharing evidence-based content on Instagram at hormone.md.hamilton. So thank you so much for joining us today, Dr. Shea, to discuss this fascinating but absolutely frustrating symptom of brain fog during menopause. And
Yes.
very excited to have you here.
Thank you. Thank you for the invitation.
Yeah. Many women describe feeling that their brain just isn't the same during the menopause transition. How does a woman know that this is brain fog? What is the cluster of symptoms that she may experience typically, which come under the category of brain fog?
Yeah, so very common that will come in and they'll say that they have brain fog, they're not thinking clearly, they might feel like they're underwater. The most common things are word finding difficulty, a word that you knew for many, many years, also challenges with working memory. So that would mean somebody tells you a phone number and you have difficulty repeating it back. Some people feel that they have more difficulty multitasking or they're not working as fast. So processing speed, which are all different domains of cognition. So very common, really common around the time of the transition and even the first year after the final menstrual period. And for many of these things, it does get a little bit better. Important to make sure there's nothing else that could be contributing. So really, we know that sleep is often not great during this time. And if you're not sleeping well, all of these things are going to be worse. So looking at your sleep, optimizing your sleep, and thinking about if there's anything else in your metabolism or in your body that could be contributing. So making sure that your thyroid's working normally, make sure that you're not low in vitamin B12. And if there are other things, like if you have diabetes or hypertension, certainly we want to look at optimizing those because they can all affect how our brain is working.
Hmm. So, from what I understand that you've explained, is that brain fog could be multifactorial. It doesn't necessarily have to be something that is peculiar to the menopause transition. It can have many different reasons as well. But are there more women who complain about it closer to the final menstrual period? And if let's say we've ruled everything else out, would that be the first step, ruling everything else out and then looking at menopause as the cause?
Yeah, certainly. But again, just optimizing sleep. Because even if we have hot flashes, I have, half of women come to my clinic and they come back and they're still not sleeping great, even though we've optimized the hot flashes. So there's something else that's going on. They're waking up in the middle of the night. They're not having a restful sleep. And I think treating that first and foremost is what we need to focus on. And then anything that's left, we want to consider all other factors and consider, always the first step is also just to do the baseline blood work. Another thing
Mm,
I failed to mention is making sure that you're not anemic. So we know that low ferritin levels and low hemoglobin, which are not uncommon if you're in perimenopause and you've been having heavy bleeding. Certainly another contributor to not feeling quite as clear, and often
right.
supplementing with iron or an iron supplement sometimes through the IV can help with that as well.
So basically, what you're saying is there could be something direct, but a lot of these are indirect symptoms of menopause, which, if addressed, could perhaps take care of the basic symptom of brain fog.
Yeah, most definitely.
And you mentioned that the symptoms or brain fog is more clustered around the final menstrual period. Does it get better for most women? Because I think the worrisome part for a lot of women at that time is what happens next? Is it going to get better?
Yeah, great question. So people, worry that is this indication that I'm going to have cognitive decline or I'm going to have dementia? And for the majority of people, this is not the case. And so, dementia is forgetting what season it is rather than where you put your car keys. And so we know that it gets better for most people. There are a few domains that don't get better, and one of them is processing speed. So the ability to process things in your environment and to work quickly. This is one of the domains that seems to get slower the more years we are from the final menstrual period. But people will learn and modify and adapt and have different strategies so that they can still work very well. And I like Lisa Moschini is a prominent neuroscientist. In her book, The Menopause Brain, she says that even though our brains might not work as quickly as they did before, they still work more quickly than the majority of our male counterparts. So I think we won't be at a
I
big
read that.
disservice if we're slowed down a little bit. So
Yeah, I think that was the best part of her book that I liked. It was like, oh my God, really, we are still faster than our male counterparts. That's good to know.
yeah.
So yeah, about again, women worrying about dementia. Coming to the office, let's say a 48-year-old walks in, we know that she's close to perimenopause, she's got classic symptoms, but she's really concerned about dementia. Let's say her mother develop symptoms at 75 or 80. What how do you advise, or how do you make her less anxious at that time?
Yeah, so great question. There's a lot of things we can do. So once we've ruled out the basic metabolic contributors, we want to look at what her mother's health history was. So did her mother have diabetes that was not well controlled? Did her mother have heart disease, hypertension? Was she a smoker? Did she exercise? What was her diet like? Because we know all of these will mitigate your dementia risk. So looking at that and many of the older generation of women weren't regular exercisers and smoking was very common. So those are two easy things that we can modify. And there's good data for that. So we know that moderate to vigorous exercise, and there was a recent study that showed moderate to vigorous exercise around the perimenopause predicted dementia many, many years later. So encouraging her to increase the intensity and frequency of her exercise has downstream positive effects. We also know that a Mediterranean diet has very good long-term data for dementia. And so the healthy fats, the omegas, avocado, olive oil, reducing your intake of red meat and having a lot of vegetables, fruit, legumes, nuts, all of these things have been found to be protective. And after all that, if she's optimized all that and she's still finding that she's having some cognitive issues, you can do a basic screener. So there's the MOCA or the MMSE, which are available free online. And somebody might feel better if they did a basic screener and saw that at this point there was no significant decline. But really thinking about healthy aging and brain health is a long-term project. So it should, around perimenopause is a great opportunity to think about all the things we can do for healthy aging, for our heart, our bones, and for our brain.
Mhm. Well, thank you for sharing that. What about family history of early cognitive decline? That would perhaps would we test earlier in that case?
Yeah, certainly. And if there was an early dementia, it would be important to know if somebody was carrying the ApoE3 gene, which can be associated with an earlier dementia. So a good idea to figure that out and get genetic testing if there is a family history. There is some data that those who carry that gene have a greater response to menopause hormone therapy for brain health. So there seems to be an interaction. So that would be an important thing to know.
But coming back to now, since you mentioned menopause hormone therapy, and is there enough evidence to support the use of menopause hormone therapy for women who complain of brain fog?
So really important question, and we're asked this all the time. There's a lot of information on social media or claims that hormone therapy will prevent dementia. And at this point, I don't think we have the data to truly say that. It may, but I don't think we can say that full stop. If that was the case, then it would be in our clinical practice guidelines. I think that what we do have is some randomized control trials that are of shorter duration, so anywhere from 4 months to 7 years. And what they did is they compared those using hormone therapy to placebo, and they found that there was no improvement in cognition or cognitive scores over the time. There was no worsening. So perhaps that's a positive. But in terms of long-term data, we are seeing some emerging database studies. So there's some data coming out of Korea and some coming out of some of the Nordic countries, and that there may be a signal that those who used hormone therapy earlier in life have less dementia. The question is it a healthy user bias, right? We know that people who seek out hormone therapy are more looking for more preventative measures. And for example, my menopause clinic and the one in Mount Sinai in Toronto, 85 to 90% of women coming through the clinic identify as white. I'd say 2/3 of them at least have a university degree. And so these are the people coming and seeking out hormone therapy versus the people that may not be as educated that or might not be seeking it out. That's the question. Is it the people that are more educated seeking this out and they have more other tools versus a healthy user bias, right? We just need to consider that when we're thinking about all of that. And so I think with longer term perspective studies, which I think we'll have maybe another 5-10 years, like from the SWAN study and the Canadian longitudinal study on aging, I think we will have more data on that looks at all of these things. But with big database registry studies, we can't really get to the bottom of all the different things that might have influenced.
And I think that that's interesting. I think it's also sometimes a relief for women to hear that even if there may not be a benefit, there may not be harm with use of hormone therapy when it comes to dementia because of the WHI memory study, which basically said we have a higher risk of dementia if we are on hormone therapy. Could you explain that a little bit so that it's clearer to our audience?
Yeah, no problem. So initially, there was a thought that menopause hormone therapy increased your risk for dementia. So the initial data from that was from the WMSI study, which was a memory study, part of the Women's Health Initiative. But the issue is that the majority of people in this study started the hormone therapy in their 60s when they looked at this. And so what we know now is that there seems to be a window of opportunity for potentially a protective or at least no increased risk for dementia if you start within that first 5 to 10 years after the final menstrual period. And there seems to be some changes similar to what we see in the risk for cardiovascular disease if you start it later. And so this has been seen in other studies as well, in that the later initiation may be detrimental for both your brain and your heart, but earlier seems to have no increased risk. There were a few other database studies that have come out in the last 3 to 5 years showing an increased risk for dementia or Alzheimer's with hormone therapy as well. But when they actually looked at what people were taking, most of them were not taking micronized progesterone. They were taking more synthetic progestins, which certainly has a different effect on the brain, because we know micronized progesterone can increase a BDNF, so brain-derived neurotropic factor, so it can be very protective for the brain versus some of the more synthetic progestins, which are in most of these large registry studies, were not does not mirror what we typically give now today.
Mm. Thank you for sharing that. And I think Dr. Mosconi's paper also highlighted the healthy cell bias, again, sort of explaining that starting it earlier may be beneficial or maybe not, but at least it may not harm us, but starting it later would probably be a problem. Um, you mentioned a range of factors. We talked about hormone therapy, but brain fog can be a result of so many different factors. And would correcting them then through hormone therapy make a difference? So you explained right now was the impact on dementia, but for a woman who is 45, not sleeping, and she can, if you say exercise is going to make it better, but you know what? I'm just so tired, I can't go exercise. And I'm not sleeping, I've got hot flashes. Um, do we have any studies that show any benefit on current symptoms of brain fog, maybe via other mechanisms of lowering vasomotor symptoms or better sleep or better mood issues?
Yeah, so certainly we have observational studies showing that there is some improvement in cognitive function and in mood once you treat the hot flashes, and certainly once you fix the sleep, then people say that they are feeling better and they report feeling less foggy. And I see this all the time in clinic, saying that that just the estrogen alone really helps their brain fog. And we know that there are estrogen receptors in so many places in your brain, and if they're not getting the same stimulation that they're used to, then theoretically it does make sense. So we know that there's estrogen receptors, in parts for learning and memory. There's estrogen receptors, a lot of them in the prefrontal cortex. And so this is important for memory and also for response inhibition. So when people are feeling like they're more snappy, that perhaps some of that has to do with the estrogen receptors in your prefrontal cortex as well.
Mm. And for those who are not interested in hormone therapy or have contraindications to it, you mentioned a range of other things that they can still do to help their brain fog. Um, would are there any I know supplements are a very sensitive topic, and mainly because the evidence body can be very shaky when it comes to supplements. But are there any that you would think of suggesting if someone was, had contraindications to the use of hormone therapy and wanted to tap into that?
So there is some evidence for B vitamins if you are found to be deficient. So good idea to check that. We know that B6 and B12 are really important for regulation of other neurotransmitters. So you may get some benefit from that. The problem with supplements in Canada and in the US is they're not regulated. And so what you get in one tablet might not be the exact same in the next tablet. And it would be easier if things were more regulated, but unfortunately that's not the case. In terms of other supplements, there is a signal for soy to help for some people, but that's really if you can convert it to the phytoestrogen, which is only about 35% of North Americans can convert it. So, but if you can convert it to to the phytoestrogen that is helpful, there are some studies that show that there's benefit. In terms of other supplements, magnesium has been found for some people to help with sleep. And so if you're helping your sleep through magnesium, you may feel clearer. And we know that magnesium is really important for other neurotransmitters such as GABA and through NMDA as well. In terms of the other supplements, there are green tea extract, but that seems to be more beneficial for males rather than females, at least the data we have to date. But I don't think it would be of any harm.
Is that L-theanine, the green tea extract? Is that
No, the green tea extract, well, there's green tea and then there's a green tea extract, which is matcha.
Oh, matcha, I guess then sticking to the morning hours, considering it does have matcha is rich in caffeine, right? So so is it the antioxidant part of matcha which helps
Yes, yeah,
probably helps brain fog?
the antioxidant, yeah.
Um, Finally, if there were three pieces of advice to a woman who walks into your office saying that she's losing her edge, she's going through perimenopause, what are your three pieces of advice to her?
Sleep first and foremost.
Mm.
If there's a role for hormone therapy, adding that. And if that's still not good enough, I do prescribe ADHD medication for women. There is a one randomized control trial, and considering Vyvanse, even without a diagnosis of ADHD, can be helpful for some women, provided that you have normal blood pressure. So this is certainly something to consider and was really helpful for many women. And then there's more than three because it has to be
More than,
optimizing.
let's hear some more then. Yes.
And then it's got to be, Mediterranean diet,
Yeah.
um,
Yeah.
reducing processed foods,
Yeah.
and increasing exercise.
Yeah. Yeah. So what I hear is there isn't a single quick fix to brain fog. It's like everything else in menopause. It requires a range of things for us to be actively engaged with. Um, Nothing or nobody's coming to save us. We've got to save ourselves.
Yes, we have to look at the whole picture. It's not just a one pill quick fix.
Yeah.
We have to.
Could you share some more information about ADHD and the perimenopause, adult onset ADHD? Yeah.
Yeah, so it can be really difficult to disentangle. So people will come in asking about ADHD. We do know that there's a much higher ratio of diagnosis in childhood, but once we get to adulthood, the ratio is about 1 to 1 for female to male. And I think many women are misdiagnosed or they're not diagnosed with ADHD when they're younger, even though they should have been because they mask in other ways. And they're often not disruptive in the classroom. They're able to use other strategies to get by. And as we get older and we have more tasks and more responsibilities, it's more common that you may notice there's some symptoms that may overlap with ADHD, and more women are seeing that and they're asking for testing. The difficult time is it's when you do the adult ADHD questionnaire, many of the questions overlap with brain fog in perimenopause. And so, did you forget what you were doing when you went into the room? Do you have trouble organizing and remembering things? And so a lot of the questions really overlap, and it can be really difficult to disentangle in the perimenopause. And you may meet the criteria, and it might be ADHD or it might be menopause. And sometimes we can't say for sure. But at the end of the day, one of the ways we can help these symptoms is with the ADHD medications. And if you feel better, then often that can suggest that you might have an ADHD diagnosis. But it's also important to look at your family because we know that 80% of people with ADHD have a family member with ADHD. So if a woman comes in and she's wondering, ask her about her kids. So are there any kids or other family members that have ADHD? And we know now that there's a strong genetic component. So ask about, behaviors in childhood, car accidents, being disruptive in school, fidgeting. For me, I used to get detentions for fidgeting in grade 3 and poor penmanship.
Really?
Yes, which is, you could not get away with that now. And I'm part of the criteria for ADHD, and my son has ADHD and many other family members. But, I was just, I got detentions for fidgeting and poor handwriting. And so, but I was able to compensate in other ways because I was, a very strong student in math and so many other things. And I had a good memory. And so, it wasn't thought that I could have ADHD.
Mm. Well, you definitely compensated way beyond the normal population. So it's quite amazing to hear this now because like when we were young, we never heard ADHD. We never heard of it, and then suddenly during when while raising my children, I suddenly started to hear more about ADHD, and now hearing about adults having ADHD, which was not diagnosed. So now is so it's not new onset. It's basically ADHD that existed and now is becoming more symptomatic. Is that
Yes.
how it is?
Yeah. And so I think it's, multiple demands plus the hormone changes. We know that Estrogen, when you give estrogen therapy, you can change the dopamine secretion in your brain. So this is another piece of the ADHD picture is your dopamine signaling can be not typical. In a neurotypical person, your dopamine signaling is often not typical. And so when you get changes in estrogen levels, that's going to influence your dopamine and it may be becoming more apparent. Plus you're not sleeping, plus you probably have kids and older parents and the multiple demands, it becomes more apparent because it's a kind of the perfect storm.
Mm. And if there is an overlap at that time and they're unable to differentiate, would it be justified to sort out sleep and maybe the vasomotor symptoms and maybe with some hormone therapy and see if they still exist and then run the test for ADHD?
Yeah, that's exactly what I do. I'll treat all these things once these are optimized and there's nothing else going on metabolically. Then I ask them some questions, but I don't do a formal diagnosis. I often will just offer them a stimulant and see. And then if it works well, then that's pretty diagnostic.
And how long does one need to be on a typical ADHD drug to know that it's working or it's not?
Pretty quickly, like pretty quickly. Some people even don't take it on the weekends, and that's the case often for kids too. It'll take mini drug holidays, and that's often if they're not sleeping. Some kids they don't sleep as well when they're on it. Their appetite is suppressed and they're not growing, and so many women also will only take it on working days, and they won't take it on non-working days, and so it can work just that fast onset. But I'd say really like give it a 2-week trial and see how you do. It's nice that it's pretty quick.
Yeah, that is so interesting because MHD can take so long sometimes to kick in and monitoring the dose and making sure that you're getting enough. So it's good to know that this can be figured out much quicker than with hormones. Anything else about brain fog that you'd like to share with us?
I think just echoing just what you said before, that it's not one thing, it's everything. You have to look at everything, and it's an opportunity to show the glaring things that you need to change in your life, just like in all these things you're going to do to help the brain fog are going to help your heart too. So your brain and your heart, they're the same things affect them negatively, and you can't see the heart disease because it's a long-term thing, but we know the heart disease is the #1 killer of women. But anything that's affecting your brain is affecting your heart too, and affecting your blood vessels. And all these changes we can do can help long-term for both of these. And I think actually one last thing, just to really stress the importance of sleep. And so I have a lot of my patients on sleeping medications, the dual orexin receptor antagonists, or the DORAs, like Quvik or Dayvigo. The reason is we know now that long-term poor sleep increases your risk for dementia. So another thing for long-term brain health. So often people are reluctant. I don't want to take a sleeping pill. I don't want to be addicted. But often if I say the words dementia, and especially if they've had a family member with dementia, then they say, okay, no, I need to protect my brain. So really protecting sleep is really, really important.
Yeah. DORAs are the new kids on the block, and do we have any long-term data on how they may impact our risk of dementia?
So we, just like any newer medication, we don't have long-term data. They've been available in the US for much longer. So I think for about 3-4 years. And from that, we don't see any increased signaling. We actually see a decreased risk for falls in nursing homes for people taking Dayvigo. So that's important because we want people to sleep so that they're feeling better, and it doesn't increase your risk for falls. So that's good positive data for the elderly. But we don't have long-term data, but we have long-term data that poor sleep long-term affects your cognition.
Absolutely. We also do have data on hot flashes being related with hyperintensities in the white matter, right? So, perhaps time to look closer at hot flashes and sorting them out as well.
Yes.
I love what you said about this being an opportunity for us to look at our health, because heart health is brain health, and the other way around. And yeah, thank you so much for this, for your time and for sharing your insight. And I'm sure it's going to be path changing for a lot of women, motivating for a lot of women to do a lot of small different things to get their brain health better. Thank you
Yes.
so
Excellent.
much.
You're welcome.
Thanks again for tuning in to Menopause Wise. Stay informed, stay empowered, and I'll see you in the next episode as we continue to navigate the menopause journey together. If you're a healthcare provider interested in collaborating with us or have insights to share, we'd love to hear from you. Please email us at info@menopausewise.com. That's wise with a Z. And before we go, a quick medical disclaimer. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. Always consult your physician or a qualified healthcare provider before making any decisions regarding your health or any medical treatments discussed in this podcast. While we strive to provide accurate and up-to-date information, this podcast does not replace professional medical consultation, diagnosis, or treatment. If you have any concerns or symptoms that require medical attention, please seek advice from your healthcare provider.